We're just back from the ASH 2024 meeting in San Diego, and we're a podcast, as you know, dedicated to hematologic malignancies. We bring content experts who live and breathe a particular disease to talk about the latest advances in biology and clinical management. And we're delighted to have our first of our ASH review series, 3 fantastic episodes we've got coming to you. This one focused on lymphoma, held just last week in San Diego, the ASH annual meeting. And so we're delighted to be joined by Dr. David Russler-Germain, lymphoma clinician scientist at Washington University in St. Louis. Dr. Russler-Germain does both translational work, focused particularly on follicular lymphoma genomics, as well as clinical trial work with expertise in the use of bispecific antibodies and in the use of circulating tumor DNA. And just because I know he won't plug it, I can plug his ASH education book article on bispecific antibodies is definitely worth a read. So thanks so much for joining us for our post-ASH episode, David.
It's a real pleasure to be here. Thank you so much for having me.
Now, I'd love to dive straight in and start with a few of the key trials in mantle cell lymphoma, particularly to begin with the update on the Triangle trial. And to those of you who haven't yet listened to our episode with Martin Dreiling from last year, I'd highly recommend it. But to recap, the Triangle trial was a 3-arm, 870 patient study run throughout Europe in young and fit patients with mantle cell lymphoma, untreated mantle cell lymphoma, that compared a Nordic-style regimen of alternating R-CHOP and R-DHAP with autologous transplant in CR1. It was a 3-arm trial. So the first arm was that standard of care arm. Second arm was an arm where ibrutinib was added to induction and given for a fixed duration of maintenance for 2 years. And a third arm where the autologous transplant was instead replaced, rather than the ibrutinib added, the ibrutinib replaced the autologous transplant. So tricky trial design, but hopefully those of you who've heard the previous episode are familiar. And the failure-free survival, similar to PFS results, were presented at ASH in 2022. And it's important to note that 60% of patients receive rituximab maintenance, because that practice sort of changed halfway through the trial. And so, unsurprisingly, at 4 years now, the ibrutinib arm had a superior failure-free survival compared to the autologous transplant arm, with a 4-year failure-free survival of 81% compared with 70%. So, and then when the autologous transplant plus ibrutinib arm was compared with the ibrutinib arm, there was a similar failure-free survival, but with increased toxicity for the arm that got both transplant and ibrutinib. And so, David, before we come to the overall survival results, those failure-free survival results comparing the 3 groups, what do you think the takeaways are there and from this update in the Triangle trial?
Well, thanks, Eddie. The Triangle trial is really a fantastic study, and I think, especially in a disease as uncommon as mantle cell lymphoma, exploring 3 arms and powering it to do multi-arm comparisons is really ambitious and really advantageous for the field. I think, there are quirks to some of the statistical analyses, since some of them were powered more for superiority as opposed to there being non-inferiority assessments that are suitable between every pairwise comparison. But I think the data are really striking and convincing, statistics aside. The failure-free survival of adding ibrutinib both during an induction and maintenance, I think is very convincing. It accentuates or helps deepen responses and enhances their durability, especially since it was only given, the BTK inhibitor that is, for the 2 years during maintenance, and there weren't imminent relapses upon cessation or stopping of the BTK inhibitor. So it's not that you're purely controlling a patient in PR with the BTK inhibitor and they're going to relapse it as soon as you stop it. This is really, I think, altering the trajectory of the disease course for the vast majority of patients.
Yeah, totally. And, on that note, if we move to the overall survival results, really the headline of this update, the 4-year overall survival was 90% in the ibrutinib arm, 88% in the arm that got both transplant and ibrutinib, and 81% in the transplant alone arm. So a 9% absolute overall survival benefit at 4 years of adding ibrutinib in the front line setting. And noting that 81% in the transplant arm is pretty similar to the 80% in the MCL younger trial, which was the kind of previous large trial. And I think it's important. We didn't get any information on post-progression therapy in Martin's presentation, but what do you make of the overall survival data and how it might influence your practice?
I think there are situations in clinical appraisal where cost and toxicity are pushing against certain novel interventions that you're sort of scratching your head as to, well, is this more toxic, more costly, more cumbersome thing for my patient worth it or not, with a much, especially in settings with much smaller clinical benefit. Whereas, the hazard ratio for OS here is approaching, roughly even 0.5. This is the relative risk reduction for an overall survival standpoint is massive. And in an era where there are even safer BTK inhibitors than ibrutinib, namely acalabrutinib and zanubrutinib, which I think most people would feel comfortable swapping in to a triangle-like approach, the fact that you can very seemingly safely, for the vast majority of patients, I would argue, omit an auto transplant, which has its own massive toxicity, especially short-term and financial implication, that I think the change in practice should be imminent, not further delayed until the OS data are even more mature. I think the OS data are icing on the cake, and the failure-free survival data should be practice changing.
Yeah, absolutely. And I think in a clinical setting where I had access, I would totally agree. And swapping in for a second generation BTK makes sense. I suppose two sort of follow-up questions on the nuance around that. The first is, how much you think the benefit of the BTK during the induction is. And, if you're going to swap in Acal or Zanu, you're going to swap it in during induction. And then, maybe I'll start with that and then come to the second one in a sec.
Yeah, I think my answer to that is very much informed by the EA4181 results and even the EA4151 results, which we'll talk about later in the next few minutes, because I don't think we have data to say that the BTK inhibitor is required to be used in induction to achieve a higher UMRD rate before moving to consolidation or maintenance. And the EA4181 trial, which compared BR and high-dose Ara-C and rituximab versus BR alone with acalabrutinib versus BR plus Rituxan and Ara-C with acala, so another 3-arm trial, had very essentially identical CR and UMRD rates, to me suggesting that the benefit in triangle comes from the maintenance phase predominantly, especially because it was alternating the R-CHOP with BTK inhibitor and then the R-DHAP without. And there are a number of centers who follow the MCL Younger approach by just doing the R-DHAP times 3 to 6, to be honest, followed by a transplant and maintenance rituximab, which, as you mentioned, has roughly 80% 4-year PFS or EFS. So I think for me, I'm putting more stock in using it as a maintenance therapy, especially considering the variability in induction approaches across the board.
Totally. And so I think the question here is sort of twofold. How are you going to approach high-risk patients, however you define those patients? And, we'll come to MRD, but putting the MRD question to one side just for a second, is autologous transplant and CR1 in mantle cell lymphoma completely dead, or are there still settings that you would use it?
I struggle with that. I think overall, it'll be very few and far between that I recommend auto and first CR for somebody with mantle cell lymphoma. And the few reasons are one, it is a condition of older patients, so you already can exclude people. I would honestly say 65, 60 or older. I don't think it's necessary for them. There's not a proven benefit, and I know it's going to take a toxicity toll. Then you take younger patients, and there's, complementary and dovetailing downsides to the high-dose chemotherapy, time off work, time away from family, et cetera, that I'm not sure exactly which patient is the one that is benefiting from the auto. And so I think when we ask patients to undergo an auto, you need data like in second-line Hodgkin's or second-line, third-line, DLBCL in different eras to say, there's a difference in the curative fraction by doing this high-dose chemotherapy. I'm not sure what I can really hang my hat on in mantle cell lymphoma using the auto. And again, as I mentioned, the BTK in induction is informed by EA4181, and the role for auto is informed by EA4151, where patients with undetectable MRD were randomized to maintenance rituximab with or without the auto. Roughly 2/3 of people, if not more, with frontline mantle cell with modern induction are going to be UMRD before they are evaluated for transplant. And that study showed, as we'll talk about, no benefit to the transplant over just maintenance rituximab. So the argument is then, is a MRD positive or a PR patient the one that should go to auto? Well, one side of the argument would be yes, because that, you're just trying to convert them to a better response. But that's also the patient likely to have the shortest remission, and then they may relapse when they're still recovering from their auto, and then getting them appropriate second line therapy becomes that much trickier. So I haven't quite settled on that one yet.
Okay, well, let's talk about EA4151, which Tim Fensky presented in the late-breaking abstract session on the Tuesday morning. This was, I think, a really well-done treatment de-escalation trial run through ECOG. Again, for untreated transplant-eligible patients with mantle cell lymphoma aged 18 to 70. And I thought the design here was quite clever because they included patients who received any induction regimen as long as they were transplant eligible, which I think is handy to kind of increase enrollment. And then they used measurable residual disease, or MRD, detection by clonoSEQ at a level of 1 × 10⁻⁶. And there were 4 arms, although the 2 arms we're most interested in, I think, are the MRD negative arms, because that's where the randomization was. And so patients who were MRD negative by clonoSEQ at the end of induction treatment were randomized to either receive an autologous transplant plus maintenance rituximab or maintenance rituximab alone. And in terms of the characteristics of the patients in the trial, the median age was 60, and about 75%, so 3/4, received intensive induction, and only 7% had triangle-style BTK inhibitor in induction, or the other trial, the other ECOG trial you mentioned. I think it's important to note that 25% or 65 patients of the patients randomized, MRD negative patients randomized to receive a transplant, in fact, refused that transplant. And so the authors performed both an intention to treat and an as treated analysis, and I'll definitely let you comment on that. And the 3-year findings with overall survival as the primary endpoint were that there was no difference in overall survival, 82.1 versus 82.7% in the intention to treat analysis, 86.2 versus 84% in the as treated analysis, and similar results for progression-free survival with no difference in 3-year PFS, 76.6 versus 77.4% in the intention to treat analysis, and 81 versus 80.4 in the as assigned analysis. So what do you, building on your previous comments, what do you make of the impact of these results?
I think it speaks to a few points. First being that undetectable MRD at end of induction for mantle cell using clonoSEQ at 10⁻⁶ is actually quite powerful. There's the CLL and myeloma MRD arenas, which are, I think, quite well established and integrated into many practices and trials. There's the other end of the non-Hodgkin's lymphoma spectrum of DLBCL and FL, where it is very much in research use only and on IITs predominantly so far. But I think in mantle cell lymphoma, it is a very strong, favorable prognostic signal to achieve that UMRD at end of induction. And again, not definitively saying what we should do for every MRD positive patient, but with 2/3, if not greater, of patients after induction being MRD negative with our current approaches, being able to confidently spare them an auto transplant and just move on to maintenance rituximab plus minus BTK inhibitor, I think is a fantastic step forward for the field. And, because transplant is not a pharma drug, so to speak, different people view the burden of evidence required to use it in different settings differently. Whereas I think pharmaceutical products are viewed through a different lens. And I think in this case, we need to ask, where is the prospective evidence to use auto and in what population? What is the number needed to treat to give who an auto to accomplish what. And I am not seeing that right now. I think I'm pretty convinced, especially with the triangle OS benefit, to do maintenance rituximab and plus BTK, irrespective of what induction patients received.
Yes, totally. And I think the design of the trial kind of facilitated that. What do you make of the kind of two analyses and the approach? You know, do you think the 25% dropout rate in A is of significance or doesn't really change your interpretation of the result?
I don't think it changes my interpretation. The OS and PFS deltas were less than 1 or 2% across all endpoint comparisons, irrespective of the analysis. And so there's not an obvious benefit to an auto in any of those analytic approaches. I think it would be harder to know what to make of if there were drastically different outcomes in the as assigned versus intention to treat populations. But between arms, that is, there were differences in the OS and PFS by several percentage points across the statistical comparisons. But between arms within a statistical assessment, the arms all looked identical on those pairwise comparisons.
Yeah, and it's not surprising that as treated, results look better than the intention to treat analysis because you're gonna have unexpected events in both arms. And so before we move to the next trial, how informative do you think the arm C results are? That is, the results in the MRD positive at end of treatment patients, all of whom went on to receive, or all of whom were recommended to go on to receive an autologous transplant. They put a nice slide comparing the patients, obviously this is a non-randomized comparison, but comparing the patients who converted with those who didn't convert to MRD negativity post-transplant. What did you make of that analysis?
Yeah, I'd love to know in a parallel universe what R plus BTK inhibitor would have accomplished for these patients. And so I think my personal practice in moving forward, integrating the two ECOG trials plus triangle, would be that if my patient is MRD detectable at the end of induction, but in either a PR or a very good PR or a CR, I would be more adamant that they should proceed with doublet maintenance, actually, like R-Acala or R-Zandu in my preference, than if they were in an MRD negative CR, I could say, at least given the EA4151 results, without BTK maintenance, you still have pretty good outcomes with just maintenance rituximab. I would still probably encourage everyone to consider the doublet maintenance given triangle, but it would be a much stronger push that the appropriate standard of care should be doublet maintenance in MRD positive mantle cell, just because that should give those patients as much benefit as much possible benefit from the evidence of these trials as possible. I don't think the auto, especially in this population, is the solution necessarily.
All right, so we'll go next to the Enrich trial, the phase 3 Enrich trial, which compared continuous ibrutinib plus rituximab versus chemotherapy, which could be either R-Benda versus R-CHOP or R-CHOP in transplant-ineligible, newly diagnosed mantle cell lymphoma over 60 years of age. And they chose chemo regimen in the control arm prior to randomization. So just a brief note on what kind of patients were enrolled in the study. So the median age was around 74 years, 90% were stage 4, 6% were blastoid, 40% had a Ki67 more than 30%, and 25% had TP53 mutated disease. One important point to note here is that the BRIGHT randomized trial, as well as the STILL trial, both have shown that BR is superior to R-CHOP. In the BRIGHT trial, for example, the 3-year PFS was 65% with Benda rituximab versus 35% with R-CHOP/RCVP. So basically, in the Enrich trial, 4-year follow-up, it was a positive study, met the primary endpoint of PFS. The median PFS was 65 months with continuous ibrutinib plus rituximab and 42 months with chemotherapy. However, when you look by the chemo, the 5-year PFS was 52% with IR versus only about 19% with R-CHOP. So there was a huge magnitude of difference between IR and R-CHOP. But when you look at IR versus Benda rituximab, it was 51% versus 47%. So not a huge difference. When you look at cause of deaths, there were 44 deaths in the ibrutinib rituximab arm, 45 in the chemo arm, and the infection, non-COVID deaths were similar. COVID deaths were 9 in ibrutinib rituximab, slightly more, about 14 in chemo arm, and the cardiac deaths were also similar, 8 versus 9. Patients with blastoid disease did better with chemo, as did patients with high Ki-67. So with that background, David, what is your take on the data, and how does it change your practice in the current?
Yeah, this trial is also fantastic. I mean, it did enroll, I believe, 2015 through 2021. So it's hard to integrate all of the conclusions into today's practice. I think, R-CHOP as a definitive frontline induction is not a modern standard of care for mantle cell lymphoma, irrespective of atypical histology or Ki-67, that patients are better served by BR or a Nordic style approach or purely a cytarabine-based approach. But that said, I mean, the last 10 years of mantle cell lymphoma research have really been heavily influenced by multiple single-arm phase 2 frontline studies of chemo-free approaches, either doublets or triplets. And it's almost too much phase 2 data to know what to make sense of. Cross-trial comparison being super, super tricky, these often being single center where patients are flying in from out of town to get treated. And so this type of a comparison on Enrich is really fantastic to see. I mean, some of the quirks are that, you can't fault the investigators for the decision at the time, but the continuous or / indefinite ibrutinib is something that is going to be a point of contention for people moving forward, because it's hard to directly compare for a patient what an indefinite therapy versus a time-limited therapy looks like, especially since you could use the BTK inhibitor either as time-limited maintenance or as second-line therapy for the patients getting DR, for example, in this population. I mean, also the quality of life and the AE data are also quite nuanced, and I don't think anyone's going to have a very there's going to be a lot of nuanced takes on those data, because depending on how you slice and dice it, it can look favorable or unfavorable for either arm. I mean, there's 22% grade 3 or higher cardiac events with the ibrutinib plus rituximab. That is a lot. And so even though there was a mid-induction quality of life improvement from IR, I'd love to see how that boils down comparing BR versus R-CHOP, and or what the longer term quality of life area under the curve looks like for patients who are getting year 2, 3, or 4 of ibrutinib versus. But in the end, I think what this really speaks to is that for a patient who either logistically or medically does not, or preferent, or just personally does not want a chemotherapy-based approach, you can have very good and I'd say comparable outcomes using a BTK inhibitor plus rituximab doublet in lieu of Rituxan plus chemo, when that chemo would be one of these lesser intensive, so non-high dose cytarabine containing approaches. The quirks would be, would we use a second generation BTK inhibitor today, acalabrutinib or zanubrutinib? And I think hats off to the Alliance. There's the 052101 study in patients with newly diagnosed mantle cell, either 70 or older, or 60 to 69 with comorbidities precluding frontline transplant, where patients receive 6 months of R-Zanu, and if in CR are randomized to continued Zanu versus retreatment at progression with Zanu. And so this study is actively accruing and will take several years to read out, of course, but this is asking a really relevant question now that we have both the Enrich and the Triangle data under our belts. So I think they had good foresight for planning that study now that we have these data in hand.
Yeah, it was really interesting to see, because in Waldenstrom's, we struggle with the same question, that whether ibrutinib rituximab or ibrutinib single agent is superior to BR, because all the trials in Waldenstrom have used single agent rituximab as the control arm and not BR. So yeah, it's good to see that at least in MCL, they were pretty similar, the PFS, and there was actually a large multi-center retrospective study done led by Mayo Clinic comparing ibrutinib versus BR in Waldenstrom that also showed similar PFS. Considered that it was retrospective, but interesting data.
Yeah, I mean, one little quirk that I know Eddie has heard me mention before is that I do think quality of life on a trial is a surrogate for quality of life in the real world setting. In the UK or the European healthcare systems where, patients probably don't have significant BTK inhibitor copays, maybe the point I'm about to make is less relevant, but probably between 10 and 25% of my patients on BTK inhibitors have a 4-figure monthly copay for it, somewhere between $1,000 and $3,000 a month potentially. And so we need to seek free drug from the company or financial assistance. But even let's just say, the out-of-pocket cost for the indefinite frontline BTK inhibitor is $5,000 out of pocket a year. That is not incurred and factored into the quality of life assessments on any of these types of trials. It's not like the control arm gets a bill, nor the study arm gets cash. So I do think there are meaningful implications of how drugs get paid for and administered and whatnot in the real world.
We certainly won't find any disagreement on that topic from me, which you know. So I think we've now, for anyone who doesn't like mantle cell lymphoma, we've got to talk about the many other types of lymphoma. So let's jump next, I think, to the aggressive lymphomas, particularly DLBCL. And the Polarix trial first presented at ASH in 2021. The updated data was presented by Gilles Salles. And just to recap, for anyone who hasn't read the Polarix or read the Polarix trial recently, it's a randomized controlled trial of almost 900 patients with untreated diffuse large B-cell lymphoma of polatuzumab vedotin, CD79 antibody drug conjugate plus RCHP versus R-CHOP, 6 cycles of each. And the 5-year data really was quite similar to the initial 2-year data presented in 2021. The 5-year progression-free survival, 64.9% versus 59.1%, so a difference of about 5.8% at 5 years compared to 6.5% at the primary analysis at 2 years. And then the 5-year overall survival, 82.3% in the Polarchip arm, 79.5%. So no statistically significant difference in overall survival between the arms. So what do you make of these updated Polarix data?
I think people, especially by the time we got to the Pola-ODAC, were anticipating that an OS difference would not be seen with longer follow-up, since the bulk of the lymphoma-related mortality events in large cell lymphoma should be captured by sometimes a 2, if not a 3-year follow-up landmark, as opposed to much longer there. Useful signals to see here are some of the secondary malignancy rates not being, quirky in either direction. They presented a number of, subgroup analyses to make the point that there was not a particular favorable or adverse signal in any one of them from the study author's perspective. I think, where I still would push them on is what to make of the cell of origin signal. This is something that we've published on, and as have others, that, Pola appears to be preferentially active in ABC cell of origin subtype DLBCL. Multiple prior single-arm clinical trials and preclinical studies would suggest that to be the case. And then that was exactly the strongest interaction coefficient from a subgroup with the Pola benefit in Polarix panned out exactly that way. And lo and behold, you look at the 5-year OS data, and the hazard ratio for GCB versus non-GCB is suggestive of like a 50% benefit for OS in the ABC subtype. And so I don't mean this, some people say, well, if you parse cell of origin in Polarix, you're telling people that it dilutes the signal and you shouldn't use Pola in one setting or another. And that's not the case at all. I think the authors may have benefited from hanging their hat the other direction and saying, this is such a clear standard of care in non-GCB/ABC DLBCL. Look, even though it's an quote unquote underpowered, they really mean not like debatably pre-specified analysis, should we be depriving any patient this magnitude of a potential OS benefit? Probably not, in my opinion. And so I think the Polarchip regimen is the standard of care for non-GCB DLBCL in the frontline setting, and it's an option for GCB disease.
Well, you really have left me with no choice but to ask you about our abstract and to comment further on that topic. So in Australian politics, it's called a Dorothy Dixer when someone from the same side of politics asks a nice and easy question for their colleague. Tell us about this government's success in X topic. So tell us about your and my abstract from ASH on exactly this topic.
Yeah, so we were very intrigued at the POLA ODAC by the cell of origin signal, especially with some of the more nuanced data, more granular data, I should say, that the FDA shared in the context of the clinical benefit of the POLA-containing regimen in ABC subtype DLBCL. And so at that time, we rallied the troops. We called on all of our lymphoma friends around the country and said, let's just look at people getting POLA and compare the outcomes of those with GCB versus non-GCB disease. And at that time, the predominant use of POLA-containing regimens was in the relapsed refractory setting, but in the coming year or so, people began using POLA combos in the frontline setting. So we thought this needs to be done formally. We have had a pre-specified statistical analysis plan, several power calculations to say, look, the prior evidence out there, which were retrospective analyses of cell of origin interaction with POLA, would suggest an upwards of 20+% improvement in overall response rate to POLA-based regimens in non-GCB large cell compared to GCB. And that's counter to what the prognostic signal of these cell of origin subtypes would be with neutral drugs, where the GCB subtype tends to be the lower risk subset. And so we assembled a cohort of 740 patients, roughly 300 receiving POLA-based regimens in the frontline, 440 roughly receiving POLA in the relapse refractory setting. And we hit our mark, that nail right on the head, that the overall response rate to POLA-based regimens in the relapse refractory setting and that for non-GCB patients was roughly 60% compared to only 36% in patients with GCB disease. That magnitude of difference was roughly mimicked or in the CR rate of 36 versus 18% in non-GCB versus GCB patients. And there was indeed a PFS benefit, has a ratio of about 0.64 for patients receiving POLA in the relapse refractory setting, where most of the benefit might be coming from POLA in their cocktail compared to in the frontline setting. Our secondary endpoints were also looking in the frontline cohort for their response rate differences, PFS differences, et cetera. And I think the key thing that we had to convey to the abstract reviewers and the audience is that in Polarix, there was not a difference in response rate between R-CHOP and POLA-R-CHP. So in patients getting POLA-R-CHP in our cohort, we would not expect inherently to see a significant difference in response rate in the frontline setting between GCB and non-GCB disease. However, the key point is that non-GCB should be adverse risk for PFS. And so the null hypothesis is that patients receiving frontline DLBCL treatment, GCB patients should do better than non-GCB patients. But in fact, in our cohort of patients receiving POLA-R-CHP, that adverse prognostic signal is overcome or negated by the fact that these patients are receiving POLA-based regimens. And so the two cell of origin cohorts have essentially identical PFS. So everything really checks the box in the right direction from what we hypothesized. And I think just further supports that there is this real POLA cell of origin interaction.
Okay, well, thanks. And before we get too nauseating talking about our own data, let's move on to talk a bit about some bispecific data in the DLBCL space. So obviously at EHA and ASCO last year, we had the STARGLO randomized trial. There were many bispecific abstracts at ASH this year, but no phase 3 readouts that I saw. So I wanted to sort of just ask you, what did you find the most kind of useful, intriguing, practice influencing, thought-provoking among these many bispecific abstracts?
Yeah, so I think there's sort of two abstracts that are complementary. One, the first as the lead-in being some of the first larger sized real world data regarding bispecific use in relapse large cell lymphoma that not unsurprisingly response rate, CR rates, and PFS tend to be worse in the real world setting than in the clinical trial setting. And so in light of that fact that our clinical trial data is sort of our upper bound of what we should expect for the efficacy of these 8 new agents in the real world, I was very intrigued by the englumafusp alpha data from the Genentech Roche group, which is trying to further augment the activity of CD3, CD20 bispecifics in relapse lymphomas. And so this is a really interesting molecule. We had this study open at WashU, and I, the inpatient service, took care of one patient who was on the study. Essentially, it is a bispecific antibody-like molecule where it's kind of looks like an IgG molecule. One arm is anti-CD19, so finding a way to bind the target tumor B cells. But the other arm, as opposed to being anti-anything, is actually just 4-1BB ligand. And so that is meant to provide the quote signal to T cells when their signal 1 drug, aka glofitamab, is what's bringing that CD3 positive T cell into proximity to the CD20 malignant B cell and triggering killing. And so this was a study that that included patients of multiple indolent and aggressive lymphoma histologies. They did several dosing approaches. But some of the interesting results was that in the aggressive lymphoma subset, the CR rate was 57%. So a very promising signal, higher than what we would expect from single agent glofitamab alone. Median progression-free survival was actually 9.7 months, which is roughly double what was seen, albeit there are quirky shapes of the curves from the single agent glofitamab data, with 1-year PFS rate 45 to 50%, and a reasonable plateau on the curve. And so this drug is administered a first dose on cycle 2, day 15, I believe, and then concurrently with the glofit on cycle 3 and thereafter. So you get sort of like a little bolus of it, and then it's given concurrently with the glofit thereafter. So I'm not really sure what their registrational strategy is for this, like where it's going to go from here. But I think the fact that their first attempt to improve on the activity of single agent glofit shows this magnitude of a signal really gives me optimism that there are going to be other ways to continue to augment bispecific antibodies without just the additive effect of a cytotoxic agent like GemOx or something.
Yeah, and I think I agree there. I mean, we've treated a number of patients with that drug at our center as well, but I agree they're certainly intriguing both scientifically and clinically. You mentioned a number of the real world studies. My observations from the 2 that I saw of bispecifics in large cell lymphoma were that the patients who received bispecific antibody post CAR T cell therapy, who had rapidly either been primary refractory to CAR T cell therapy or rapidly progressed in those first 3 months, did pretty poorly. What do you think the implications of that are, both kind of mechanistically and clinically?
No, I think that's a major point, that many of the centers that are using bispecifics as standard of care are the same trial sites and CAR T centers, because there hasn't been the same level of community bispecific uptake as planned. So you're already like saying that most of the patients who can get a bispecific antibody are probably those that also have CAR T on the table. And then because it's the same providers and same patient cohort, if you're giving somebody second line CAR T cell for their relapsed large cell, irrespective of their age, and you have a stable disease or PD at day 30, and you're asking what off the shelf thing can I give them, why would you pull out DHACs, if that wasn't the preferred option in second line when CAR T beat that? So I think people pull out bispecifics, and then you have crummy T cell, somebody that's still recovering from lymphodepletion, a tumor that may not be responsive to T cell killing really. And so you're puttering on a little bit further. I think I don't have strict guidance on what I tell someone to do in that sort of 1 to 6 months post CAR T relapse. Ideally, a clinical trial or some novel approach would be ideal, but what you should expect for your patient should be very much tempered by how soon after CAR T they're getting their bispecific. There's no way around that.
Let's move to talk about 2 trials in follicular lymphoma. First, a randomized phase 3 trial presented also in the late-breaking abstract session by Laurie Sen from Canada. 550 patients in the InMind trial were randomized to receive either tafasitamab, which is a CD19-directed monoclonal antibody, plus R-squared, lenalidomide rituximab, or R-squared, lenalidomide rituximab, plus placebo. And I thought it was really great that they did an IV placebo in this trial, because it makes both the efficacy and toxicity data so much more interpretable. And so these 550 patients had follicular lymphoma grade 1 to grade 3A and had at least one, and indeed median of one prior line of treatment. In terms of the patient characteristics, median age was 64, a median of 5 years since their initial follicular lymphoma diagnosis. 80% were advanced stage, 75% had grade 1 or grade 2 follicular lymphoma. 83% met Guelph criteria and 30% were POD 24, that is, they'd had progression of their disease in the first 2 years after induction treatment. And so the top line results were investigator assessed a progression-free survival of 22.4 versus 13.9 months with a hazard ratio of 0.4, which was consistent across subgroups. And indeed, there was a positive overall survival trend, which is too early really to assess in follicular lymphoma. So what do you make of these data, and where do you think tafasitamab fits into the follicular lymphoma landscape?
Yeah, I think Dr. Lorsen did a great job presenting these very intriguing data and giving a comparison to the Augment study, which established our-len over single-agent rituximab as a preferred second-line regimen, since there were a number of differences between the Augment population and the in-mind population. Where I struggle with, if I can lead with that, is that I think a lot of people are sort of scratching their heads at what the single agent activity of tafasitamab is in FL. There's very scant clinical trial data to say how active is this drug as a monotherapy. And so even with this very impressive PFS improvement, it's almost it feels a little too good to be true for a drug that like didn't catch on as a monotherapy or a combo therapy in a later line. And so I think a lot of us are colored by that input. Second, as I mentioned, compared to the Augment population, that study had no rituximab refractory patients, whereas 42% in-mind enrollees were rituximab refractory. And so there's the point made in the presentation that, you know, the control arm of in-mind, the our-len arm, had worse outcomes than expected compared to the our-len arm in Augment. But if you flip it around, you could say that the control arm in mind performed very similarly to the lenalidomide only arm in an alliance study, 50401, where len was plus or minus R. So the other randomization than Augment was performed. And so in that study, when you give someone with relapsed lymphoma, relapsed FL, lenalidomide alone, the median time to progression is 13 months. And that's pretty much exactly what was seen in this population and in mind of where roughly half of the patients, you know, so to speak, were rituximab refractory. So I think not to say that we have perfect data to say what to give somebody with second-line follicular lymphoma. There's a lot of 2 versus 1 randomized studies out there, like Benda versus Benda, our-len versus len, et cetera. But I think it begs the question. I really want to see the manuscript here for patients in their second line of therapy versus third line and beyond. What had they previously gotten? What were they truly sensitive to, or versus just exposed to? You know, people that are not patients that don't have POD24 and have a frontline remission of 6 or 7 years to frontline BR plus minus maintenance rituximab are well served by many different things. And I don't know if adding TAFA to our-len for those patients is the right answer or not. So I think it's very provocative and exciting data. Like improving outcomes by this degree is a great step forward. But since there's no label for TAFA in FL yet, I'm not sure it's going to be taken up off-label imminently.
And what did you make of the toxicity data? Sort of small increases, 9% higher diarrhea, a bit higher in COVID, 5% constipation, 4% nausea. They're all the differences that I've just fished out between the two arms.
I think some of those can actually be potentially boiled down a little bit to the somewhat laborious scheduling of tafasitamab. I mean, we see a lot of the nausea and constipation, the diarrhea that happens with some of these regimens can very well be attributed to infusion-related things or pre-meds, you know, especially if you're getting a bunch of DEX or you're getting antiemetics, like you're getting more Zofran for your infusion reaction, but then that constipates you. So the fact that you get weekly TAFA for 3 months, I think, that's a lot of stuff that's happening to you. So it's not only kind of an inconvenient regimen, all things considered, but there's a, depending on how much infusion pre-meds you need, either Benadryl, antihistamine, steroids, et cetera, you can certainly accumulate a few percentage point higher adverse events here and there, especially if you're producing, as you would expect, even more profound like B-cell ablation with the dual antibody approach. So it'd be really cool, really interesting, not cool, but interesting to see whether the patients with, certain GI side effects maybe, or those that have IgG levels below 400 mid-therapy or something, like, can it be linked back to the mechanism of action of the drug, or does it seem more random?
Quickly want to touch on a single center phase 2 trial. We watched together the phase 2 single center trial at University of Miami of Loncastuximab tesirine, which is a CD19-directed antibody drug conjugate that is approved and used in DLBCL with, I guess, modest efficacy. It was a 39-patient study in relapse refractory follicular lymphoma, patients who'd had at least one prior systemic treatment, of whom about half had R-CHOP and about a quarter had BR, and 20 of those 39 were POD24. And it was a 10-month fixed duration combination treatment with rituximab. Now, the overall response rate was 97% and 12-month progression-free survival 94%. 94.6%. So obviously 12 months is early to look at something, and it's 39 patients, but what did you make of these data, David?
Yeah, when I was after the meeting, when we watched this, I went back and only realized then how under the radar the 2022 and 2023 Lonca FL data really snuck under people's attention spans, to be honest, I think, with all of the bispecific data coming out. So, I mean, you go back and you say, okay, back in the early days of Lonca development for large cell lymphoma, 50% response rate, 25% CR rate, toxicity non-trivial given some photosensitivity and effusions, especially in this multiply refractory large cell population. Then you're factoring in it's a CD19 target, and that's where we're aiming CAR Ts at. Oh, and by the way, we have multiple competing CD20 bispecifics, which are very sexy mechanistically, don't have the same cumulative ADC type toxicity, and maybe there's a curative tail to the plateau curve for those patients, for that drug. So I wonder if Lonca was sort of the right drug in the wrong era. Had it been developed 3 or 4 years prior to when it was, that it would have had better uptake in different settings. And so with that as a background, and then you look at the FL data and you say, oh, 13 of 15 in one study had a overall response, most of those being CRs. This seems to be, especially in this time frame, reasonably well tolerated. I think this has legs. I'm not sure like what line of therapy I would use it in, second, third versus fourth. I mean, the people that have Lonca toxicity, definitely they don't like it, and it's not like you just stop the drug and it immediately gets better. I mean, if you're talking about a retiree in their 70s getting second or third line FL treatment and they want to go golfing, being on Lonca in Florida in the summer is going to be a real crimp in their style, given the photosensitivity and some of the, if there's any skin, nail, or other cutaneous toxicities. But I think for the right patient, I think it'd be really interesting in the future if there's any small anecdotes of using this in bispecific refractory patients, like say somebody on Celestimo or some of the EPCO-R-LEN studies moves on to this. I think it's a reasonable option, and especially for a patient who logistically can't get to CAR T cells for third or fourth line FL, if one option for your patient, then maybe this is a temporizing measure and maybe durable. We'll have to see.
Yeah, I think it's very intriguing, certainly. Warrants further investigation, as so many presenters say in this setting. Okay, so I will just do the intro to Amplify.
Yeah, knock them out both real quick, and then I'll talk. Yeah.
Okay. So next, let's move to a CLL abstract, which was simultaneously published in the, well, not simultaneously, which is soon to be published in the New England Journal of Medicine, which is the Amplify trial presented by Jennifer Brown from Dana-Farber. 867 patients with treatment-naive CLL. It was a multi-center open-label phase 3 trial, which excluded patients with TP53 aberrations. They were randomized 1-to-1 to receive 14 cycles of acalabrutinib plus venetoclax versus the same number of cycles of AV plus obinutuzumab versus either FCR or bendamustine rituximab, so chemotherapy. And whilst it was a one-to-one randomization with about 290 patients in each arm, it is important to note that 31 patients withdrew from the chemotherapy arm after randomization. And if we look at the headline results, the 3-year progression-free survival was 83% in the AVO arm versus 76.5% in the AV arm versus 66.5% in the chemotherapy arm. And both novel arms are powered for statistical comparison against the chemo arm, but there wasn't, as with the previous trial of acalabrutinib in the frontline setting, there wasn't power to directly compare the two acalabrutinib venetoclax arms. Undetectable MRD to 10 to the -4 was higher in the AVO arm. And it is important, though, to notice that the OS results were the other way around, with higher overall survival in AV compared to in AVO. So AV overall survival 94%, AVO 87.7%, and 85.9% in chemotherapy. So looking at these data in combination with the infection data, it does make me wonder about the benefit of adding obinutuzumab. So would love to hear your thoughts about these data and how they might influence your practice in frontline CLL.
Regarding the Amplify study, I think the CLL frontline space is very complicated. Outcomes are generally, very good for patients receiving either monotherapy, doublets, or even triplets of our sort of non-chemotherapy agents. And choosing between them is going to be a real struggle. There's good evidence from Jake Sumerai at Mass General looking at Bovin, which uses a different BTK inhibitor than the Amplify study does. They reported similar uMRD4 rates of around 95% and are following it up with an MRD adapted trial where treatment duration is based on magnitude of MRD reduction at certain landmarks. There are several industry-sponsored studies, such as MAGIC and others, that are looking at antibody-free novel agent combinations in the frontline setting, time limited, of course, but duration dependent on time to MRD clearance at certain landmarks. And so I'm not sure how Amplify changes my practice yet, other than giving me a little bit of pause regarding adding an anti-CD20 to a BTK inhibitor plus BCL2 mimetic doublet. Personally, I'm not using the doublet AV or any other combination off trial. I would be either using venetoclax with obinutuzumab or single agent BTK inhibitor. So I would love to see, maybe in a fantasy land, some way of starting with monotherapy, such as acala monotherapy, and only escalating to add venetoclax if, with 1, 2, 3 cycles later, we're not getting the depth of response we wanted, sort of needing to justify the degree of combination therapy, since these could be given sequentially.
All right, so finally, we'll touch upon Hodgkin lymphoma, and we'll go over the study of pembro maintenance instead of autologous transplant in relapsed refractory Hodgkin lymphoma who are in a complete response after pembro GVD, the abstract by Moskowitz et al. So just for the audience, so 36 patients in PR after pembro GVD, 2 to 4 cycles were included in this trial. They got 13 cycles of pembro maintenance, 11 were treated off protocol, 6 chose ASCT, 4 chose ASCT due to pembro toxicities, 2/3 had ABVD or AVD, and 1/3 had BVAVD. The 2-year PFS with this approach was 60%, and of 24 patients, 10 have relapsed, 4 patients during pembro maintenance, 3 within 3 months of completing pembro maintenance, 3 more than 3 months after completing, and 9 of those proceeded to transplant. So David, what do you make of this data, and how does this fit your current practice?
Yeah, this was one of the real gems, in my opinion, of things that I really wanted to know from this ASH. I think there were a number of other studies that were potentially practice changing, but this is something that I think all of us really wanted to know for people that treat a lot of Hodgkin's, as I do. So, backing up, irrespective of what we should be doing in the frontline setting, whether it's ABVD, BVAVD, NevoAVD, escalated via copper, BRCAD, we can save that for a separate conversation. I think for the last 2 to 4 years, the standard of care for most patients in the second line setting was to receive pembrolizumab plus GVD based on Alison Moskowitz's single center phase 2 study, out of Memorial Sloan Kettering, where the overall response rate and the CR rate were both like 90 to 100% essentially. All patients minus one, I think, on that study had then underwent an auto, and the 1-year PFS was also better than 90%. So that really changed the standard of care for relapse Hodgkin's, from often people just getting standard ice and going to transplant to now getting pembro GVD, which doesn't require inpatient admission for chemo, then going to transplant. And the question was, is this novel salvage combination so potent that patients could just skip the auto? You know, if the CR rate to the salvage is 90+%, how deep are those remissions? And so I believe it's a separate arm of the same umbrella trial at MSK, but either way, they ran in parallel or sequentially, either way, this study that we're talking about, where instead of getting the auto, you just got more pembrolizumab. And I think it's quite striking that the delta is that the 2-year PFS is actually as low as 60%. That's a huge difference for the auto. Now, what was very elegantly explained is that essentially the vast majority, if not every patient, could be subsequently salvaged and go to an auto transplant in 3rd or 4th relapse in this single center study. But that does require patients to have longer periods of active disease over their lifetime trajectory, longer treatment durations, whether they're getting single agent BV ice, BV benda, ice alone, et cetera, in the 3rd or 4th line setting. And then if half of patients who omit the auto need the auto roughly, then that's about as good of a number needed to treat as we can see in any disease, really, right? I mean, we're talking about pembro GVD plus an auto curing. I mean, I quote my patients 85+% cure rate after that regimen. If you started, not even just getting to the auto, it's starting that regimen. And so Sloan Kettering is very wisely asking a study of the follow-up question in a large randomized phase 2 study of 180 patients or so, of patients getting pembro GVD in the relapse setting, followed by randomization after 2 cycles to either the auto now or auto after subsequent salvage, with the primary endpoint being 5-year freedom from disease. So a very meaningful post-salvage landmark. But right now, I think, you know, we can contrast this with the evidence for auto in mantle cell lymphoma, where we're really seeing many studies say it's not that helpful. This is a study that says it's actually super helpful. And these are typically younger patients in whom the auto toxicity is much less than in the typical mantle cell lymphoma patients. They still get the same B conditioning. So this really answered a major question in the field, in my opinion, and I think didn't change my practice, but really strongly reinforced my practice that these patients should not just omit the auto until we have further evidence of the salvageability beyond a single center study.
Thanks so much, David, for a fantastic conversation. I really appreciate your insights and giving us your time today.
Well, thank you, Eddie. Raj, also, it was great to see you both at ASH, and these are, you know, very exciting lymphoma abstracts that I think many of which are practice changing.